Hi everybody, and welcome to our module on neurocutaneous disorders. Neurocutaneous disorders are also known as phacomatoses, and these are a number of rare genetic disorders that involve mainly the skin, nerves, and eye. That's why they're called neurocutaneous. Although, as we'll see later in this video, sometimes other structures are involved in particular disorders like the bones or the kidneys. And the idea here, and what you want to understand about these disorders for step one, is that most of the structures involved in neurocutaneous disorders are structures that come from the ectoderm. In the reproductive section, I talk about the germ layers, and in that section, I talk about how the ectoderm gives rise not only to your nervous system structures like nerves in the eye, but also to the skin. So you can imagine that a genetic abnormality of something in the ectoderm could later in life lead to problems that involve both the nerves and the skin. And that's how neurocutaneous disorders work. So there are four of these disorders. They're all very rare that you should know for step one, and we'll go through them all in the next few slides. We'll start by discussing neurofibromatosis, which is a familial cancer syndrome. It's a genetic disorder. It is autosomal dominant, and it involves mutations of two genes called NF1 or NF2, and they get their name because they're related to the disorder neurofibromatosis. NF1 is the most common type. That's what we'll spend most of our time talking about. And the hallmarks of this disorder are nerve tumors called neurofibromas and also skin and eye findings. The most common form of this disorder, neurofibromatosis 1, is also called von Recklinghausen disease. It's a mutation of the NF1 tumor suppressor gene found on chromosome 17. This gene encodes for a protein called neurofibromin, which is a tumor suppressor protein. The normal role of neurofibromin is to restrict a growth protein called RAS. So when there's a mutation and there's abnormal neurofibromin, this leads to RAS overactivity, and that can lead to uncontrolled cell growth. This disorder is autosomal dominant with 100% penetrance. That means all gene carriers have disease, and the children of an affected individual have a 50% chance of disease. However, you should know that this disorder is famous for the genetic phenomena called variable expressivity. This means that not all affected patients have the same severity of disease. Some have mild features and others have severe features. This is the phenomena of variable expressivity. It's called neurofibromatosis because patients with this disorder develop neurofibromas. These are benign tumors of nerves, and they often develop in cutaneous nerves, and that leads to these bumps on the skin. If you ever meet a patient with this disorder, and I've met one or two in my career, it is very, very disfiguring because of these neurofibromas, these bumps all over their body, including their trunk and their face. Remember that most of these neurocutaneous syndromes affect the skin, but also the nerves and the eye. So the eye findings in neurofibromatosis are called leash nodules. These are brown spots on the iris. If you look at this picture of a person's eye here from someone who has neurofibromatosis, there are brown spots on the iris. Those are the leash nodules of neurofibromatosis. So we've talked about the nerve findings, those are the neurofibromas. We've talked about the eye findings. Now let's talk about the skin findings of neurofibromatosis. The classic skin finding is a café au lait spot. Café au lait means coffee with milk, and these are light brown macules that you can see on the screen. This is a picture of one shown here. In addition, freckles are very common and people who have this disorder. They're usually not random. They cluster in the skin folds, especially in the axilla and groin. These are unusual places for freckles to be found. So those are the main findings of neurofibromatosis. Some other findings you can see are shown here. Optic gliomas are common. They usually develop by 3 years of age. This is a rare tumor of the eye. If you look at this picture on the right side of the screen, this is an image of a child with an optic glioma. That's this large mass here behind the eye. Bony abnormalities are also common. Usually it's curvature of the long bones, but it may also be a facial deformity of the eye socket, and it can also be scoliosis of the spine. And then finally, many of these patients have some degree of intellectual impairment. Patients with neurofibromatosis type 1 can develop hypertension through a couple of mechanisms. First of all, they sometimes develop renal artery stenosis, and in addition, they can rarely develop pheochromocytomas. And then finally, patients with this disorder can develop malignant tumors. Remember, they have lots of neurofibromas, and over time, some of them can become malignant. Usually it's not the skin lesions I showed you before, it's these deeper nerve tumors called peripheral nerve sheath tumors, and this often happens in adolescence or adulthood, and the way this usually presents is as pain or sudden growth of a neurofibroma that is deep to the skin. Shown on this slide are the diagnostic criteria for neurofibromatosis. You don't need to memorize this, but all of these criteria should make sense to you. Patients to have a formal diagnosis of neurofibromatosis must have 6 or more cafe au lait spots, 2 or more neurofibromas, freckles in the axilla or groin. Remember, those are the unusual locations for freckles. An optic glioma, 2 or more leash nodules in their eyes, or a bone lesion, or a first-degree relative with neurofibromatosis type 1. Most likely on your board exams they will describe an adult who has many of the features of neurofibromatosis, but just so you're aware, the features tend to evolve as a person ages in a typical fashion. First 2 years of life, people with neurofibromatosis develop cafe au lait spots, bony abnormalities, and optic gliomas. And in fact, the diagnosis of an optic glioma in a young child should prompt a workup for potential neurofibromatosis. From 2 to 6 years of age, that's when the eye findings, the leash nodules develop, and that's where the developmental delays become apparent. And then at adolescence or puberty, this is when the cutaneous neurofibromas occur. We'll just briefly touch on neurofibromatosis type 2. This is much less common than type 1. It is also autosomal dominant, however, it's a mutation in the NF2 gene. And the main feature of this disorder is central nervous system tumors. In particular, bilateral schwannomas are very common. Schwannomas are also called acoustic neuromas, and these occur in almost all patients who have neurofibromatosis type 2, and that's what you want to remember about this disorder. In addition, many of these patients develop meningiomas. In the neurology section, I talk about brain tumors, but I'll briefly review schwannoma here to help you remember it in terms of neurofibromatosis type 2. This is a malignancy of Schwann cells, which are glial cells of the peripheral nervous system. They are not neurons. Classically, the tumor is located to cranial nerve 8, and that's why it's called an acoustic neuroma, because the presenting signs and symptoms are often hearing loss, tinnitus, and ataxia. These are all features related to cranial nerve 8. And then on imaging, you will see a tumor present in the central nervous system. This is an example of one on the left. You can also see one on the right side of the screen. Moving on, our next neurocutaneous disorder is tuberous sclerosis. This is also a familial cancer syndrome, and the hallmark lesion of tuberous sclerosis is the hamartoma. Hamartomas are benign malformations of cells and tissue, and the cells and tissue resemble the tissue of origin. So for example, a lung hamartoma is made up of lung cells and lung tissue, but is disorganized and formed into a mass lesion. The same is true of hamartomas in other organs like the skin or the spleen or the heart. And one of the main clinical features of tuberous sclerosis that you should remember for board questions is seizures. That's because CNS hamartomas develop, and that's what leads to seizures. This is an autosomal dominant genetic disorder. However, new or de novo mutations account for 80% of cases, so many individuals with this disorder do not have a family history because they're the first person in the family to carry the genetic mutation. In addition, tuberous sclerosis has variable expressivity, so not all individuals in an affected family will have the same degree of disease. The genes that cause the disorder are labeled TSC1 or TSC2. TS stands for tuberous sclerosis. The TSC1 gene codes for a protein called hamartin. The TSC2 gene codes for tuberin. Both of these are proteins that inhibit something known as mTOR. mTOR stands for the mechanistic target of rapamycin. It is a kinase enzyme, and so when there's a mutation, mTOR is not normally inhibited and it becomes overactive, and that leads to cell growth, especially growth in cell size. And this is what leads to non-malignant or benign cells, but they are overgrown in size and they form a disorganized ball, which is a hamartoma. Tuberous sclerosis leads to widespread tumor formation in multiple organ systems. Usually the tumors that form are hamartomas, although in some cases they are other neoplasms. However, if you just remember that hamartomas are the hallmark lesion, you can usually answer questions about this rare disorder. It is hard to remember all the different organ systems that are involved. Some classic features are shown on this slide, and we'll go through these in the next few slides with some pictures. Seizures are the most common presenting feature, especially in a young child with a mass lesion in the brain. One of the things you should think about is tuberous sclerosis, especially if other features are present. Like most neurocutaneous syndromes, there are CNS features like seizures, but also skin features. So let's talk about the skin features. The classic finding is an ash leaf spot that's a pale hypopigmented skin lesion, basically a white spot on the skin. I'll show you a picture of this in a minute. Another hallmark lesion are facial skin spots called angiofibromas. And then finally, there's intellectual impairment, which was formerly called mental retardation, present in tuberous sclerosis, just like in neurofibromatosis. That is often an element of the neurocutaneous syndromes. Some of the CNS tumors you can see in tuberous sclerosis are detailed on this slide. Cortical tubers are distorted portions of the cortex. This is what can cause seizures. There are several of these in this image on the bottom left side of the screen. There are these white parts lighting up in the cortex. Subependymal nodules are nodules in the ependymma, which is the lining of the ventricles. There are several small white dots in this picture on the right side of the screen. That is evidence of subependymal nodules. Patients with tuberous sclerosis can develop subependymal nodules, but they can also develop a larger, more serious subependymal lesion called a subependymal giant cell astrocytoma. This is a low-grade version of the tumor astrocytoma, and it usually occurs at the intraventricular foramen, as shown in these pictures on the screen. And when this happens, this can obstruct the ventricles and lead to hydrocephalus. So it's high yield to know that patients with tuberous sclerosis can potentially develop hydrocephalus, and they can present with papilledema and other findings consistent with raised intracerebral pressure. Rhabdomyomas are benign tumors of muscle cells, and they are the classic cardiac feature of tuberous sclerosis. 90% of rhabdomyomas occur in children who have tuberous sclerosis. Sometimes these are detected on prenatal ultrasound. You can see the tumors embedded in the ventricular wall. Often they're asymptomatic, but sometimes they cause symptoms by obstructing the outflow of the left ventricle or by causing an arrhythmia. And I talk about rhabdomyomas in more detail in the cardiology video on cardiac tumors. Here's a picture of angiofibromas. These are fibrous papules, usually on the face. This is a classic feature of tuberous sclerosis. And here's a picture of an ash leaf spot. Basically, it is a white spot on the skin. It's a hypopigmented macule. It's usually oval or elliptical, like this example shown here. A shagreen patch is another potential skin finding in tuberous sclerosis. It's a connective tissue hamartoma. It's usually found on the lower back, and it leads to a lesion like what's shown on the screen here, which is usually described as having an orange peel or leathery texture to it. And once again, this is just another hamartoma, the classic lesion of TS. There is a nail finding sometimes seen in TS. It's called an ungual fibroma. This is a fibroma beneath the nail bed, and it looks like this picture shown on the screen here. Renal angiomyolipomas are the most frequent kidney or renal manifestation of tuberous sclerosis. Often, children with this disorder have multiple tumors that are bilateral. It's caused by a proliferation of epithelioid cells around a vessel. That's why it's called an angiomyolipoma. Sometimes these tumors can grow and then hemorrhage, and that can lead to the acute onset of pain. In addition, in some cases, they cause excess renin release, and that can lead to hypertension. And there is a risk of chronic kidney disease among people with tuberous sclerosis, and that's because these angiomyolipomas can get so large they can compress the normal tissue and lead to kidney failure. And here's an image with the black arrows indicating presence of bilateral lesions in the kidneys. These are angiomyolipomas. So the classic case of tuberous sclerosis to know for your board exams is a young child or an infant who develops seizures, and then a physical exam reveals evidence of ash leaf spots and angiofibromas. If you see this, you should think of tuberous sclerosis, and then if you just know that this disorder is associated with hamartomas, you can usually answer most board questions. Okay, now let's move on to our third disorder, which is the Sturge-Weber syndrome. This is a congenital vascular disorder of capillaries. It's caused by a spontaneous gene mutation in early development. So the key point here is that this is not inherited like the other disorders we've been talking about thus far. There are three classic hallmark features of this disorder that you should know for your Step 1 exam. The first one is a port wine stain on the face. I'll show you a picture of this in a minute. This is a special type of birthmark. The second is a brain tumor called a leptomeningeal angioma, and the third is increased ocular pressure or glaucoma, which is very unusual in children, but it can be seen in children with Sturge-Weber. In terms of genetics, Sturge-Weber involves a spontaneous mutation in a gene called the GNAQ gene. This occurs after fertilization. It is a somatic mutation, and I talk about somatic mutations in the genetics section. Also in the genetics section, I talk about mosaicism. This is when some cells have normal genetic content and others contain the mutated genetic content. And as I said before, the main underlying problem in Sturge-Weber is abnormal capillary formation and growth. This is a blood vessel disorder. The classic feature of Sturge-Weber, and the one that's usually most obvious even at birth, is the port wine stain, which is also called a nevus flammeus. This is a malformation of dermal capillaries and venules, and it occurs on the face in Sturge-Weber syndrome. It is usually unilateral, and it occurs in the first and second trigeminal area of the face, just like in this baby shown on the screen here. The reason this rash is present like this is because there is slow or low blood flow in the skin on that side of the face. This leads to these pink-red patches, and it's apparent at birth. It does not regress. It grows as the child grows. So one of the major problems in Sturge-Weber is the facial disfigurement. Now, just an aside, many children are born with a port wine stain. Most of those children do not have Sturge-Weber, but in terms of board exam questions, if you see a description of a child with port wine stain, this disorder is what you should think about. Second feature of Sturge-Weber is a leptomeningeal angioma. So the leptomeninges are the pia mater and the arachnoid matter in the brain and in the skull, and they're shown on the screen here. Your meninges are made up of your dura, your arachnoid, and your pia mater, and the arachnoid and pia mater are called the leptomeninges. An angioma is a capillary venous malformation. So in a leptomeningeal angioma, an angioma develops in the leptomeninges. This always occurs on the same side as the port wine stain. It's high yield to know that, and this may cause seizures. 80% of children born with Sturge-Weber will have seizures in their first 2 years of life. This can also cause focal neurologic deficits like hemiparesis. It can also cause headaches. Glaucoma in Sturge-Weber occurs in infancy or early adulthood. The exact mechanism is not clear. It may involve abnormalities of the angle of the anterior chamber. There's also evidence of elevated venous pressure in the episclera, and also some children with this disorder have hemangiomas in the choroid. But through whatever mechanism it occurs, glaucoma can lead to vision impairment if it's not identified and treated. So one thing you have to know when you're a pediatrician is if you see a newborn baby who has evidence of Sturge-Weber, one thing you have to do is send them for an eye evaluation. Usually we don't check children for glaucoma. It's mostly a disorder of the elderly, but this is one situation where it can occur in infancy or in young children. So the classic case to know for your boards is a newborn with a port wine stain. That newborn develops seizures. That newborn may have evidence of glaucoma. What they're describing is a case of Sturge-Weber. Our last disorder for this video is von Hippel-Lindau disease. This is another genetic cancer syndrome, and people with this syndrome develop multiple benign and malignant tumors in different organs. It's caused by a mutation in the VHL or von Hippel-Lindau gene, which is found on chromosome 3, and it encodes for the VHL tumor suppressor protein. For step 1 of your exams, it's high yield to know how this tumor suppressor protein works. It leads to ubiquitination of a protein called hypoxia-inducible factor. In the cell biology videos, in the video on translation of proteins, I talk about ubiquitination, which is a post-translational modification in which a protein called ubiquitin is added to other proteins, and it tags those other proteins for destruction in the proteasome. So if you have abnormal VHL tumor suppressor protein, ubiquitination will not occur. And as we'll see in a minute, cells behave as if they're hypoxic, and this leads to blood vessel growth. And tumors involving blood vessels are very common in von Hippel-Lindau disease, as we'll see in just a minute. Here's a picture from the web to make this more clear. So when tissues are exposed to normal oxygen conditions or normoxia, the von Hippel-Lindau tumor suppressor protein binds to hypoxia-inducible factor, and that in turn binds to ubiquitin, and this leads to destruction of hypoxia-inducible factor so that it's not around. When you have hypoxia, von Hippel-Lindau protein releases hypoxia-inducible factor 1, and then it is not ubiquitinated, and it can go on to trigger the hypoxia-inducible genes, including many that lead to the growth of blood vessels. When you have von Hippel-Lindau disease, the von Hippel-Lindau protein is abnormal and it never binds to hypoxia-inducible factor. Therefore, the cell is going to always behave as if it's in a hypoxic environment, and genes are going to be transcribed that lead to blood vessel growth. And this is what happens in von Hippel-Lindau disease. If you know that, then it's easy to understand that in von Hippel-Lindau disease, patients develop multiple hemangioblastomas. These are clumps of capillaries. They are blood vessels that have undergone angiomatosis or excessive growth. On gross examination, they appear bright red because they're blood vessels. They're well circumscribed and they're benign, which means they don't invade or metastasize, but they can cause symptoms by compressing other structures or bleeding. They often occur in the central nervous system in von Hippel-Lindau disease. Rarely they can be seen outside of this disorder, but especially in a board question, if you hear about a hemangioblastoma, you should think of von Hippel-Lindau disease. And classic locations in the CNS are the cerebellum, spinal cord, and retina. And here's an image of the brain showing you one of these hemangioblastomas in the cerebellum. In addition to hemangioblastomas, there are some other tumors that often develop in this disorder. First of all, renal cysts often occur. Many of these patients develop renal cell carcinomas. They are often bilateral because it's a genetic disease. And then finally, pheochromocytomas can also be seen in von Hippel-Lindau disease. And if you just remember that the adrenal glands and the kidneys are close together, it's an easy way to remember that kidney and adrenal tumors like pheochromocytomas occur in von Hippel-Lindau disease. And I'll finish with this slide and just mention that von Hippel-Lindau disease is often held up as a classic example of the two-hit hypothesis. This means that cells require two hits in order to develop malignancy. I talk about the two-hit hypothesis in more detail in the genetics section, but by way of review, the two-hit hypothesis means that a disorder is caused by, first of all, one abnormal gene that's inherited and leads to a germline mutation so that every cell in the person's body has one mutated gene. However, for a while they have no symptoms because the other gene is normal and functioning. But then at some point in time, as a person ages, a second spontaneous mutation occurs in one particular cell, and that leads to disease. And there are other disorders that are held up as a classic example of the two-hit hypothesis. They all involve tumor suppressor genes. The other disorders are retinoblastoma. This is the disorder in which the two-hit hypothesis was first described. Other diseases mentioned in talking about the two-hit hypothesis are Li-Fraumeni syndrome and familial adenomatous polyposis. All of these are considered autosomal dominant disorders because you inherit one abnormal gene, and then when you get the second hit, you develop the disorder. In addition, the tumors in most of these disorders occur in late childhood or young adulthood, and that's because even though you're born with one germline mutation, the other gene in all of your cells keeps working until you get a little bit older, and that's when that second hit occurs. And that concludes our video on neurocutaneous disorders.